Hello and welcome to the PNHP webinar of one version of how to do grand rounds in front of a medical audience. So I'm Ed Weisbart. I'm a family physician in St. Louis, Missouri. I chair the Missouri chapter of Physicians for a National Health Program. And I thought that we would spend maybe a couple minutes, just go around the room, so to speak, the virtual room, and have folks say their name and where they're from and title if they have one. So it's kind of hard to organize that in order of how you're sitting, but go ahead and chime in if you could and tell us who y'all are.
My name is Mark Bauman, and I teach at the Indiana University School of Medicine in Bloomington, Indiana. I'm a hematopathologist and direct the second-year medical student pathology course for medical students.
Terrific.
I'm Dick Dundas. I'm a retired internist, practiced all my life in Bennington, Vermont.
Great. Anyone else on the line whose phone's not muted?
This is Dave Keeley from South Carolina, and I'm the lead person for Healthcare for All South Carolina, our state's PNHP chapter. I'm a family physician, public health physician.
And we're going to be talking later tonight.
That's right.
Anyone else on to introduce themselves? Carol? Well, all right. Why don't we go ahead and start? I thought the way we would do this is I would act in character, as if I were speaking, delivering the actual grand rounds. There might be one or two moments where I will step out of character and make a comment, sort of as an aside, but generally it'll be in character, as if real grand rounds. And I believe you can follow along the slides. I believe you have access to the slide deck, but you can use it whichever way you like.
I do.
So here we go. As I said at the beginning, I'm Ed Weisbart. I'm a family physician in St. Louis, Missouri, and I chair the Missouri chapter of Physicians for a National Health Program. And I'm delighted to have a chance to talk with you all about the healthcare situation in the United States and where we're coming from, what's changing right now, and where I think we need to be going. So if anyone in the room thinks that we have arrived at the perfect healthcare solution today, you're probably in the wrong room because we disagree, but we can talk about that. So first I thought I would start by showing you a bit about how I got connected to, my slide master's not working. There we go. About how I got connected to some of these issues, and it starts for me at one of these events. In addition to the other things that I do, I volunteer with the National Association of Free and Charitable Clinics, and this is the organization that supports the roughly, I think, 1,500 free and charitable clinics, brick-and-mortar clinics around the country. And in addition to that, they've started hosting these one-day massive events in different cities around the country. So they've done, I think, 14 so far, and I've been at 8. And what they do is they rent out the biggest convention center in town, typically, and bring in volunteers like me and others, and deliver care for free to typically over 1,000, sometimes 1,500 Americans without insurance in one day. So they get primary care, they get some specialty care, they get on-site testing, they get free medications for 3 months actually, and a number of other things. They're really gratifying days, and I recommend that you participate in one of these if you ever can. This slide here shows you what the patients look like. So there's a few things to notice. First is that it's a really long line. This line goes down to the end of the slide, as you can see, and then there's actually 2 more slides, one that turns left and one that turns left again. So there's a lot of people. It's one thing to know that there's tens of millions of people without insurance in the United States. It's another thing to see over 1,000 of them gratefully and patiently, typically, lined up waiting for care. I also want you to notice that these are not sort of street people. These are well-groomed, well-dressed folks who look like you and me when we don't have our white coats on, and they just typically don't have, 83% of them come from a household where somebody works full-time, but at a job that doesn't offer an affordable health care benefit. So we'll talk a little bit more about the patients in a moment, but this is what the volunteers look like, sort of a room full of them. This is Bobby Kapoor. He's the medical director for this particular event, and this one was in Houston. Great guy. And then this is what a room full of the volunteers look like. And I'm showing you this because when I started doing this, I sort of assumed that volunteers at these events would essentially agree with me about philosophy or politics or what have you. And I'm here to tell you that the people who volunteer for these events to take care of uninsured Americans are pretty diverse. They represent every philosophy, every political party, every apolitical party, every faith-based or non-faith-based philosophy. They're socioeconomically diverse. It's a diverse group of people. And yet they all agree that they want to spend their time volunteering to help people who really do need some help. So I show you that because we think in the United States that we're so polarized and so divided and we disagree about so much, but this is very heartwarming to me to realize that at its essence, most Americans, and actually probably most human beings, but my experience is more here, most Americans really do want to help each other and really do not want to see somebody suffering needlessly. We disagree about the politics and the strategies and the tactics, but at our core there's more agreement at that level than actually disagreement. That's encouraging to me. Let me show you a little bit more about the patients that come to these clinics. This is the typical day when we do this, and over 1,000 people. This is the typical mix. And it took me a couple of clinics volunteering at to look at this and think, well, that's really odd. And then I thought, well, what do the typical patient mixes look like across the United States? And now on this next image, you can see the typical age mix that we're all familiar with in our offices. So why are they different? Well, one of the reasons is because we have a program called S-CHIP that provides insurance to most, not all, children in the country. It's an imperfect but pretty good solution for them. And we have a solution called Medicare for seniors and a few other groups that is an imperfect but pretty good solution. And if you look at that, that changes the one group into the other group, essentially. The reason this is important is that these abstract policy decisions that we're talking about at times really make a difference. This shows up every time we hold one of these one-day events. So policy matters. So policy, healthcare outcomes. How do we look at a healthcare system across the world? This chart looks at life expectancy because I think life expectancy is probably the single clearest measure of how a system's performing, although, of course, other things feed into it. The countries that I think are scrolling up your screen, if we're not in a webinar right now, are the countries that live longer than we do, have longer life expectancies. So I'm going to show you a handful of these kinds of charts. Some will have so many countries in them that it'll be hard for you to read the x-axis, and some will have far fewer countries in them, and you'll be able to read them more clearly. It's not because I'm cherry-picking the data to make my points. I'm showing you all the data from each of these individual data sets. They come from different sources and different surveys and such, so some have a lot of countries and some not so many. But invariably, I'll have the United States stand out as a different color. So in this one, we're red on the left of this chart, 51 other countries, or 50 other countries living longer than we do. So that's sort of surprising. Some of the countries maybe not so much, but some of the countries it is surprising. And as you may have heard, seen this chart, this kind of data, we spend roughly double what most other nations spend on healthcare per person. So that part, I think most people have heard. What they may not realize is this part, which is that our tax dollars actually are already paying more. We're already paying more in tax dollars than any other modern nation is spending in total on their healthcare. So this is not data that you see all the time, but it's correct data. You have to not only include the cost of Medicare and Medicaid and the VA and the Department of Defense, you've got to include the cost of the tax subsidies that people get. You've got to include the cost of providing health care to government employees at the municipal or state or federal level. And if you put all that together, it turns out that our taxes essentially are paying for more than we're paying more in taxes than any other country, and we're certainly not getting universal health care as a result of that. Here's another way of looking at this. This is from Jerry Friedman, a professor of economics at University of Massachusetts in Amherst, and he put together this chart that shows that countries spend more on healthcare and in general get a longer life expectancy if you plot that out. It's not perfect. It's not exactly spend more, get more. But if you do the statistical analysis on this, it turns out that 75% of the variation in life expectancy is driven by the variation in what a country spends per person on healthcare. So on the right-hand side, of course, are countries that spend more and the less countries that spend less. Which one of these green dots do you think is the United States? And it turns out that it's none of those green dots, that we're this other red dot that's way off the curve. So if we were to spend at the level that we're spending, but get the life expectancy that we would get at world performance, we would be living 4 years longer than we are today. Or if we were decided that we wanted to reduce what we spend, for our current life expectancy by world performance of a healthcare system, we would be saving $6,700. So the question I would ask of the audience is, which do you prefer? If you're older like me, you probably think those 4 years is what you want. But some of the younger folks may be thinking, well, I could really use $6,700. Either way you look at this, we're not really getting, we're not performing at world standards. So, and this is a problem. The cost of our care impedes our ability to get care. So this is, again, an international survey looking at people that had cost-related problems accessing care. And as you can imagine, more people in the United States have this problem than really anywhere else, almost double most other countries. So roughly 1 out of 3 Americans say that they have trouble accessing care because of the cost of care. And this, of course, is worse among the uninsured. That's not a big surprise. But what is a bit more surprising is that even among the insured in the United States, there's still a huge problem with getting access to care because of cost. So this is sort of the good news and bad news. The good news is this is in part why I have a nuanced view of the Affordable Care Act, because it's hard to argue that going from the red bar to the white bar is not a good thing. So getting more people insured, if that really pans out to mean they have better access to care, that's probably a good thing, getting people more access to care. But even with that, you know, the white bar on this chart is still nowhere near world performance. So it's maybe a step forward, but nowhere near far enough, and we'll talk a bit more about why. We do some things well. We have rapid access to elective surgery. This is a chart looking at adults who needed surgery, elective surgery, and waited at least 4 months. So this is not emergency surgery. If you need emergency surgery, you break your hip or something of that ilk, typically most modern nations get pretty quick access. But if you need elective surgery, we are among the best. Part of the reason I'm showing you this is because if you talk to most folks about Canada in America, they would say, well, Canadians, you know, maybe they have universal health care, but they have to wait forever to have their surgeries done. And so there's truth to that, in that the Canadians on this chart had just about the worst, if not the worst, actually, performance in the world. But most Americans think that Canadians, 80% of Canadians wait 5 years for surgery. And I think it's important to know the numbers on this. And the numbers are that 25% of Canadians wait less than 4 months. I'm sorry, 75% of Canadians wait less than 4 months. 3 out of 4 Canadians wait less than 4 months. So it's not the plague that most Americans think have going on up there. And if you ask Canadians about that, they will almost invariably say, well, I hate that. And a good source for that is the healthcare movie that's got a number of on-the-street interviews with Canadians. And if you ask them, they will say, yes, I hate that. I don't like having to wait. I hurt my knee. I had trouble climbing the stairs at work, and it took me a couple months to get in, and I didn't like that. And then they will all say in the very next breath, but I know that I don't have to sell my house if I get a lymphoma. I know I don't have to go bankrupt if something bad happens to my health. And I like not living in fear. And Americans, I don't know how you'd live in this constant fear of being one disease away from bankruptcy. I don't know how you do that in America. And so, yes, I have to wait longer for elective surgery, and I get that, and I don't like that. But, you know, it's a trade-off that I make. I'd also point out that they spend roughly half what we spend. So, you know, the issue would be quite different here. We don't actually go to the doctor very much, despite how much we spend. there we are with among the fewer visits to physicians. We don't even have that many practicing physicians when you think about how much we're spending. But we do lead the world in this. We lead the world on administrators, and you see it picked up really around the rapid rise in managed care movement. So we lead the world on that. Who are these people working in healthcare today? Well, this is the most recent data I have on this is from 2008, actually. But we had at that point roughly 500,000 practicing physicians in the United States. We had a few more managers in healthcare. We had a lot more registered nurses, and we had way more people just working as office support, primarily in the offices, billing and helping you go to the right MRI place and manage your insurance and all of that. So it seems like that's a lot of people. And in fact, today, most hospitals in the United States actually employ more full-time equivalents in the billing department and related activities than they have beds. So they could have somebody positioned full-time outside of every hospital bed and have people to spare. So that's a lot of people. At the end of the day, when you add this up, all of the administrative processes that we've built into our current system require roughly 31% of our healthcare dollar. I recently retired and started having to pay my own premiums for my family, and we bought the silver plan because I'm like that, and our premium is $1,300 a month, which means that we're spending, I'm personally writing a check every month for $400 of medical administration, much of which is really not necessary. And as a fiscally prudent person, I don't like doing that. So we have insurance, but we don't have great insurance in our country. You've seen this chart. It's hard to update this chart because the events surrounding this ratio are constantly in flux, today in particular, again. So roughly that's where we were in 2011. And we know that what's happening is more and more people are shifting into this underinsured category. So some of the red is becoming more underinsured, and some of the green on this chart is becoming more underinsured. And we define that, in most studies, define that as spending more than 10% of your income on healthcare. That's, yeah, you got insurance, but you're really underinsured. So most people who are underinsured, most people who declare bankruptcy these days actually declare bankruptcy because of a medical condition that started. There's the real estate boom bubble, and we've had lots of things driving bankruptcies. But if you dial back to the beginning, why was somebody so vulnerable to that kind of a bankruptcy? It was because of a medical expense. And it's the common paradigm that we're all familiar with. You're working, you have insurance, you get sick, you have a hard time continuing at your job, you lose your job, you lose your insurance, and before you know it, you declare bankruptcy. And indeed, that's the most common paradigm. Most people who have to declare bankruptcy for a medical reason actually had insurance at the time of the beginning of this bankrupting illness. So, this is a big deal. It's affecting all of us directly. Will the Affordable Care Act predictably change this? Well, we have a way of looking at that in a couple ways. First of all, as you probably recall, Massachusetts put in a reform much like the Affordable Care Act, and they did it several years in advance. They did it in 2008. It really went live. So we can look and see what happened to these medical bankruptcies in Massachusetts as a result of their putting in their reform. So in 2007, in Massachusetts, there were roughly 7,500 people who declared bankruptcies for medical reasons. And then in 2009, the number went up, not down. So now a lot of things happened in 2008. The economy shifted pretty dramatically. A number of things happened. So I'm not here to say that their reform created more medical bankruptcies, but I am here to say that you can't make the argument that the kind of reform that's in Massachusetts eliminated or even mitigated very much medical bankruptcies. And as you know, the reform in Massachusetts was actually more generous than what's in the ACA. So medical bankruptcies are going to remain with us. And here's how this works. Here's two non-smoking 60-year-olds. Their household income is $62,000, as you can see. Their federal subsidy, well, they happen to be right above the rate that you can get a federal subsidy, so they didn't get anything. They chose the premium plan, so the premium silver plan, so a little over $13,000 in a premium. You may not realize, but in addition to paying your premium, there's a maximum amount that you can pay out of pocket, which is another $12,000 and change. in addition to their premium. So your total contribution for this couple, if they got sick, really just one illness, would have been 42% of their household income under the Affordable Care Act. And that's not counting the impact of having to go out of network. You need a specialist who your insurance company doesn't decide is in network. You want to hospitalize at some place that's not in your network. Your expenses could be considerably higher than that. So the point of this is that bankruptcies from medical conditions are going to stay with us. So there are lots of good things in the Affordable Care Act. It's hard for me to argue that having millions of more people with insurance is bad. I think that's a good thing in some ways. There are many new insurance regulations. A lot of those are really what we used to fight for as the Patient Bill of Rights. So that's in the Affordable Care Act. I'm not going to belabor that. There's many new things about the marketplaces that I'm sure you're familiar with. And, of course, the public programs are actually stronger, not weaker. So Medicare's trust fund is out longer than it's been for quite a while, and Medicaid expansion, of course, is a big deal. We're going to dwell on the Medicaid expansion piece for a bit. So let me give you a case study from where I'm from, and I'll tell you about Medicaid in Missouri and the Affordable Care Act. So I'm going to step out of character for just a moment. Obviously, if you're in a state that's expanded Medicaid, you may not want to include this part unless it's still a contentious issue. But a lot of us live in states where this is still an issue. So I'll walk you through how this works in Missouri, and then you may want to change some of the numbers for your state, but back into character. So here's how Medicaid in Missouri works. First, let's go over what Medicaid is like today in Missouri. And you have to understand Medicaid is different in every state. So Medicare, which is primarily, as you know, for seniors and Lou Gehrig's disease and renal failure and a few other things. Medicare, federally administered, federally funded, plus individual contributions, but really no role for the state to pay for it. So Medicare is almost identical in all 50 states and the District of Columbia. Medicare in Florida is the same as Medicare in Alaska pretty much. Medicaid, passed at the same time, 1965, is a little bit different. Medicaid is roughly 60% paid for by the federal government and 40% paid for by the states. Different ratio in every state, but roughly that amount. So Medicaid, because of that, Medicaid varies state by state. The law enabled each state to make their own, design their own Medicaid program within certain parameters. So let's talk about how Missouri works. Your state might be a little bit different, but here's how it is in Missouri. Across the vertical axis, there's your income as a percentage of federal poverty level. So in dollar amounts, I chose a family of 4 to show you. So 100% at the bottom there is you're at the federal poverty level, which changes every year. For a family of 4, if you earn your household makes $23,850. And of course, it's a smaller dollar amount for a smaller family size and a bigger dollar amount for a bigger family size. So in Missouri, if you're a child and your household makes up to three times the poverty level, then you can get Medicaid. There might be a premium depending on exactly what your household income is. But if you're a child, if your household makes that much, you the child, not the household, but you the child can get Medicaid. If you're pregnant, we just changed that in Missouri right now. So now if you're pregnant, you can earn up to 300% of the poverty level. I think that's effective at the beginning of next year. Blind folks, quite a bit less. Aged or disabled, that's the dual eligibles. Parents can earn up to about $1 an hour, which I believe is the average income in Angola. Parents can get a little bit, but if you're in Missouri and in many states, if you're a childless adult and don't fall into one of these other buckets, you're not going to get Medicaid in Missouri. If you're not disabled, if you're not a child, if you're not pregnant, you're not getting Medicaid in Missouri today. So the Affordable Care Act had a plan to give everybody in the country a pathway to have access to care, a pathway to affordable care. So again, using the same graph, if you were above 100% of the poverty level, but below 400% of it, and you couldn't get health care through your employer or some other program, you could go onto one of the marketplaces, or used to be called exchanges, and you could purchase your insurance there privately and get a large subsidy to your premium, really a tax credit that you could get applied every month or applied at the end of the year, whichever way you choose. So if you're down at the bottom of that chart where your income level is at poverty level or slightly above, the premium subsidy would be quite large, where your personal payment might be in the order of $20 or so. per month. And if you're at the top end of this spectrum, you'd be paying most of the bill. So that was the plan on that. And then also in the plan was that every state would still have variations in how they do their Medicaid program, but they would all say that if you're up to 138% of poverty, you're going to get Medicaid, or you're going to have access to Medicaid. So that was the plan. It was a pathway to give, in theory, everybody access to affordable health care. Well, as you know, and then there's this overlap zone in between 100 and 138%, where the thinking was if you're a wealthier, low-income person, you could make a choice. So there's that. You may be hearing numbers of 133 or 138% for that number. It's actually the exact same thing, just to get arcane for you if you're confused by that. The law says 133% of poverty, but to disregard the first 5% of income. So some people say 133, some say 138, and it's really the same thing when you come down to it. So that was the concept. And as you know, the Supreme Court decided that states didn't have to expand Medicaid. So if you're below 100% of poverty in states like ours, and you don't fall into one of these buckets, you're not going to be getting any help, really, out of the Affordable Care Act. I find this decision to neglect the population who most needs help to be, in my mind, morally egregious, but that's how it is today. So there's a lot of discussion about whether the states can afford it. You need to understand that the ACA writes in that the federal government pays for all of the cost of expansion for the first 3 years of this being in effect, which is 2014, 15, and 16, no matter when a state comes in or out of the program. So a state that expanded Medicaid in January 1st of 2014 gets 3 years of subsidies, of premium support for their citizens. And if you wait until 2016, you only get 1 year. Excuse me for a moment, I'll drink a drink of water here. And then starting in 2017, states become slightly more responsible for the cost of it, ratcheting up to 10% by 2020 and staying at that level thereon. So the federal government retaining most of the cost of the program. In other words, in our state, since we're not expanding it, we're paying for it, but we're not getting the benefit of it. So just because my state chose not to expand Medicaid doesn't mean that the federal government reduced my personal taxes. I'm still being taxed for this program, but nobody in my state is allowed to benefit from it because of my state legislature. So there's a number of controversies about Medicaid, and I thought it might be worth informing the discussion, because some of these controversies are really not founded in fact. They're founded in smoke, and it's worth your learning about it so that you can form your own informed position, and if, as I hope you agree with me, you can help advocate for getting the truth about these things out. So here's one of the first ones, and this is from one of the senators in Missouri whom I spoke with at great length, and he was of the opinion, I think I persuaded him otherwise, but he was of the opinion that giving Medicaid to an uninsured person doesn't even improve their health. Why are we doing this if it doesn't even make them healthier? And this is a common statement, and they commonly say this based on a study that came out of Oregon. And so part of the statement is true, so let me demonstrate this to you. If you don't know about this study, it's pretty impressive. In 2008, Oregon randomized people into or not into Medicaid. So they financially qualified you, and then they decided we could afford to give half of you Medicaid, or some ratio of it. So they compared the group who got Medicaid with the group that didn't. You never get that in healthcare benefits. They actually gave you a randomized controlled trial, and they found that indeed life expectancy didn't change. There was no change in the average blood sugar. Utilization increased, but the outcomes did not. So they can accurately say that there was no change in the average blood sugar, to pick on that one. And that sounds terrible. But the rest of the study is important. It was not that large of a study, as you can see here. And if you compare the average blood sugar of one population to another, when both populations are pretty much not diabetic, they wash out the impact of an average blood sugar. So indeed, in their population, 94.6% of the population was not diabetic. So the average blood sugar for both populations is kind of meaningless. But there are a number of intermediate outcomes that were very important. So for example, if you only look at the uncontrolled diabetics, you see that there was a dramatic drop in them. dramatic drop in people with elevated cholesterol, elevated blood pressure, and diabetes and all of this. If you look at the impact of activities, there was a lot more screening for lipids, a lot more pap smears, double the rate of mammography. So the reason this is meaningful is because many states like mine are saying, well, we need to make this really require that you do the preventive health care or we're not going to give you Medicaid. Well, this shows that if you just get rid of the financial barriers, people do want to start doing these things. And at the end of the day, it means a lot of better health care, better treatment of chronic disease, and hundreds less deaths in my state specifically. And there's data about this for every state. And isn't that really why we do this? I think one of the best discussions of how this gets from Medicaid back to the broader topic that we're here to discuss was from one of the founders of our organization, Dr. David Himmelstein, who said this quote that I'll actually read to you. Medicaid is far from perfect. I think we all know that. In many parts of the country, Medicaid pays so little that patients have trouble finding a doctor who will accept it. A single-payer program like Canada's that covers all Americans is a far better solution for both the poor and the middle class. But until we get to single-payer, Medicaid is the only safety net for many low-income Americans. So the biggest flaw with the Affordable Care Act, of course, is that it was written by the insurance industry and preserves the people who wrote it. So all of these problems that I'm not going to read to you really remain, if not, some of them even probably get worse under the Affordable Care Act because it was written to focus on profits rather than people. And that's really damaging in the healthcare industry to do that. So we have a better solution. We don't have to keep on tweaking a broken system. We actually have a much better solution. Let's talk about what we can learn from the world. The world organizes healthcare differently than we do. First, there's one group of countries, for example, Canada, that has a national health insurance. This is public funds, tax dollars, but private delivery. Physicians and hospitals are still pretty much organizing the way that they choose to, often in private practice or what have you. It's akin to Medicare, public funds, private delivery. So there's that. National Health Service, which is not just the insurance side, but this is actually also providing the health care. This is public funds and then public delivery, much like the Veterans Administration or in Great Britain. So a health insurance versus a health service. These two methods are often commonly sort of lumped together and called single payer, and they are in many ways. We don't really have that in the United States. It's hard to call Medicare a single-payer program because, of course, there are many other payers here. And the Veterans Administration is clearly not a single-payer program, although it has the National Health Service component to it. And then there's another method that's not that common, but Germany has it, where it's highly regulated nonprofit insurance, called all-payer, you could call it that, or market-based solutions like we have here, where there's this wealth, so to speak, of insurers, which creates huge gaps in care. So that's what we have here. We're the only country in the modern world that has that. So let's talk about a national health insurance program, because that's really what I and I believe our organization generally thinks is the best step forward. We'll explain why over the next few minutes. So it's a national health insurance, public funds, but not interfering really with the private delivery model. There are a number of things we probably need to do about the way we deliver healthcare, but this specifically is focused on the finances of it. And there's legislation in Congress, H.R. 676, that I'd recommend you read. It's 30 pages, double-spaced, pretty easy to read. This is probably, when we get to the point of it being passed, it'll probably be modified, but it's good to have a clear direction of what the best solution is. This is the best vision for where to go. And it's got a fair amount of traction. It's got, I think, 56 co-sponsors, sponsored by John Conyers from Michigan, but it's gaining more co-sponsors. It was the most popular piece of healthcare legislation in Congress until the Affordable Care Act they actually passed. So what's in this bill? It's very simple, really. It's very simple. I really recommend you read it. Just two concepts: improve Medicare and then expand it. So improve Medicare, we know things that are wrong with it. It's far from a perfect solution, although it's pretty good. So most seniors who have Medicare, if they can afford to, they buy a supplement or a wrap to deal with the fact that Medicare often has financial barriers and co-pays and deductibles. So most seniors fix that by buying a supplement or a wrap. So we know what most people think they need in that, so add that into the core offering. And indeed, that's what's in H.R. 676, and get rid of these financial barriers that do little more than actually impede care, and fix some of the gaps that are in the benefit design. So do those things. Improve Medicare and expand it to all Americans, including those in Congress and the President and the entire country. That's very important, because that's having everybody in the program means that the program is much less inclined, it can't get marginalized. It can't be something that a legislator would change oblivious to the fact that this whole population would be impacted, because they would be in the population. So having everybody in is important for that reason, and also because that's the only way you get to the efficiencies of not having to deal with which payer do I use, which insurance form do I submit, which network do I use. If everybody is in it and nobody is out of it, virtually all physicians would probably want to be in it. The efficiencies would be terrific for all of us. So that's pretty much the concept here. And then there's other initiatives that would go down this road on a state-specific basis, but a lot of ways for us to get there. One of the first questions people have is, what about the people working in the insurance industry? And you need to know that these are, I've worked, as we all have probably, with many of them. They're typically smart, compassionate folks who are doing their best to navigate through a dysfunctional system. So the bill that aligns with the policies we think are the best, HR 676, actually talks about this quite a bit, and I'd recommend you read that. There's a fully funded transition program where if you earn up to $100,000 a year in most positions, you would have your income guaranteed regardless of what happens to your employer based upon this passing. And then after that, you would still be able to get unemployment. And you would have there's a lot of attention to retraining and job placement, because these are the folks that we would still need in many ways. So it's funded. How do you fund it? Well, it's funded by consolidating the current funding programs. There is a modest increase in taxes that would primarily affect the highest of earners, and then you would get rid of financial barriers as a result. At the end of the day, in my state and in most states in this ballpark, the average worker in Missouri would save $7,500 a year that they could then spend on school. They wouldn't have to have their kids go into debt as much. They could spend it on clothes or better food or housing or whatever. Very strong stimulus to the economy instead of being diverted into the insurance industry. And at the end of the day, if you earn up to $500,000 a year, you win under a single payer model as this is being proposed. If you're above that, you would actually probably spend a bit more on your health care, but you're also then in the group that's the only group that's really recovered from the economic downturn we had in 2008. So they're probably the group that's more able to absorb that. At any rate, people up to $500,000 a year would actually come out ahead under this model. This is, again, going back to Professor Friedman from Amherst. He said, well, what if we did this? What would the savings, would there be new costs? Well, of course there would be. So you'd have to pay people more, physicians more, to see Medicaid patients, because today we don't pay very much for doctors, and so many doctors won't accept Medicaid patients. So you shouldn't be, it's just really not right that physicians are in a position to have to financially screen their patients' payment system. And this would eliminate that. All patients would be reimbursable to physicians at the same rate. So it would cost the country $74 billion by this analysis to correct that in Medicaid. There would be a cost for providing care to the uninsured, and people would start doing more things. They'd go to the dentist. And by the way, if you don't know, people want to go to the dentist more than they want to go to the doctor typically. So this is very important. I think these are good things. Now, some people stop at this point in the economic analysis and say, look, there's hundreds of billions of dollars there. We can't possibly afford to do this. Didn't you hear about the national debt? Well, that's not fair. You can't look at a spreadsheet by looking only at one side. You have to look at the savings. So instead of administering dozens of programs, the government all over the country could save some by administering the one program. Health Insurance Administration would, of course, plummet. We would finally be able to negotiate the prices of drugs and devices, which, unbelievably, we can't in Medicare. And, of course, the cost for each of us in our offices to deliver, to manage through this system would be a great savings. So at the end of the day, you could cover everybody in the country with better benefit package and still save over $200 billion. Now, there are other analyses that make different assumptions, some more granular, all kinds of different versions, but invariably the new costs are smaller than the new savings. So here's the chart that you've probably seen before, the relentless driving curve of healthcare in the United States rising as a cost of GDP. In 1971, President Richard Nixon signed the HMO Act, among other things intended to lower the cost of care. And it's pretty hard to see the impact that the HMO Act had on that curve. So interestingly, though, in Canada, it seems like in 1971, when we passed the HMO Act, Canada's cost curve changed. Why would that be, you might be wondering? Well, it's of course because they also fully implemented their single-payer program. And you see, it wasn't just a one-time drop, but they actually changed the slope of their curve. Well, I saw this chart, and my first concern was, what about health outcomes? What about life expectancy? So if you look at the same sort of data, in 1975, Canadians were living 1 year longer than we are. I don't know why. They're Canadians. I don't know. But in the subsequent, 35 years, they now live roughly 2.5 years longer than we do. So they lowered their cost curve, and they improved their longevity curve compared to us. So physicians are kind of figuring this out. Physicians, there's a rumor that physicians are flocking out of Canada, and indeed 20 years ago, a few hundred a year would leave, not thousands, a few hundred. But over the last 10 years or so, that's really changed, and physicians are actually tending to move back. Canadian physicians are moving back to Canada rather than leaving it. And American physicians over the last few years have been moving into Canada. So American physicians who choose to are actually leaving the United States and moving into Canada more and more so. So in the past, there was typically about a 3% growth in there, but now there's up to 42% increase in the last 8 years. So American physicians are migrating into Canada. They're doing it for reasons like this. It's just so much easier and, frankly, more fun to practice in a system where you don't have to worry about all the shenanigans and paperwork and loopholes that we deal with here every day. You can read this guy's quote. He moved from, I think, Detroit, someplace in Michigan, over to Ontario, and he seems much happier. So, and this is part of it here. These numbers are not unpleasant numbers. This is their income on average in each of these specialties. They compare actually favorably to the numbers I've seen of the United States. And this is their malpractice experience. So these, if you talk to physicians, the first thing on their mind typically about anything in medicine is tort reform, tort reform, tort reform. Well, the real solution to tort reform is single payer, because under a single payer model, why do people sue? A big driver of why they sue is to capture the future costs of medical care. They're sick, they're injured, they got a problem, they don't know how they're going to pay for their health care over the next several years, so they sue because that's the only thing they have left to do that. Well, in Canada, they don't have to sue to get the future cost of medical care covered. It's part of the single payer program. And if they do sue and they win, the judgment doesn't have to include the future cost of medical care as it does here. That's one of the biggest pieces of the judgment that's found against physicians when we get sued, is the future cost of care. That goes away, and at the end of the day, those premiums are a little bit lower than you typically see in the United States. And because of all this, if you survey physicians and say, do you want a national health insurance program, they say yes. 59% of physicians last time they were surveyed said yes, more in some specialties, less in other specialties, but even in the specialties least inclined, a significant chunk of us do want this. And overall, the majority of us do. And this data is old. I would submit that it's probably a higher number today if and when the survey gets repeated. The reason I'm showing you this is because although it seems many of us agree about this, we don't really talk about it very much. I didn't talk about it a few years ago. I was afraid I didn't want to be branded a kooky guy who talks about single payer. I seem to have gotten over that. But we don't talk to our colleagues about that very much, and we need to. You don't have to be afraid about it. Your colleagues probably agree with you. Start those conversations. Talk to your colleagues, and don't drive folks crazy, but at least make the passing reference and try to engage the conversation. I consider this old school social media. So anyway, have those conversations. To go back to the beginning of this discussion, I mentioned that we actually tend to agree about things. I told you the group of volunteers who tend to agree. Here's a survey that was done not too long ago, asking people across the country, are the benefits from government programs like Social Security and Medicare worth the cost? So is Medicare worth what we spend on it? And a national sample, guess what? 3 out of 4 Americans generally say, yeah, Medicare, Social Security, that's worth it. And then they went and asked the same question to people who identify themselves as being part of the Tea Party. And I'm not making this statement to speak for or against the Tea Party at all. But I think the Tea Party would probably agree that they are very, very focused on not wasting a penny of our precious resources. So what does the Tea Party think? Turns out 62% of Tea Party folks would say that Medicare and Social Security are actually worth it. This is profoundly important to me. This gets to why I'm here. I'm here because I believe that the United States is supposed to be fair, an equal opportunity level playing field, and we don't have that today. Today, your wealth determines your health, and that's not right. I believe we should be fair, and I believe most people in our country believe that too. This is the best way to get there. This is an incredibly fair solution. I'm also fiscally prudent. If you have a different solution other than something like H.R. 676, if you have a different solution that gets every American access to affordable, high-quality care, and it costs more than H.R. 676, I could probably compromise with you, but the reason I'm so much in favor of this approach is because I believe that it accomplishes all of those goals in the least expensive way. But if you don't think that's as important, if you want to accomplish the goals and you have a strategy that accomplishes them but costs more, we could probably talk about that. But you would be probably having to spend more to do any other strategy. And then lastly, the reason I'm here is I am just proudly patriotic of the United States, and it kills me to be showing you slides showing how other countries do better than we do. I grew up on Leave It to Beaver. I grew up on believing that we are supposed to be #1 in everything, and I'm here to tell you we are not in healthcare today, but we should be. I shouldn't be showing you slides of how other countries are doing it better. They should be showing slides about how the United States is the best in the world. And I'm here to tell you we have all the parts we need to make it happen. We know the system. It's called Medicare. Improve it, fix it, expand it, and give it to all Americans. And we can do that. So time for questions. A few minutes. So that's pretty much the run of show. Anybody still awake?
Hello.
Hello. Hi.
Good. Thank you for your presentation, of course. It was very thorough. Just a question about any type of spending caps on healthcare costs, because it seems every time we run up against that same wall of, the word of rationing, and of course we ration now using different measures, but there aren't unlimited funds and there aren't unlimited tax dollars available, even with the new system. How do you address the problem of limiting costs, and do you do that by establishing caps on healthcare spending?
Well, part of the reason we have, that's a great question, because obviously we have limited resources, and if we're putting in a program that's not going to address that, we would be missing one of the bigger challenges in our country. The rising cost of healthcare undermines businesses' competitiveness, and it, as I mentioned, drives people to the poorhouse, really. So it's a very important question. And the answer to that, in my mind, is that this is really the only viable strategy to accomplish controlling the cost without having to do our arcane sort of ratcheting. So part of what's in the solution that I didn't really allude to is the idea of global budgets for institutions and for hospitals and for regions, so that you have one budget for capital, you have one budget for operations, and one budget for education. And these are discrete, non-fungible budgets, which means that today a hospital really wants to capture more market share, and so if their neighboring hospital down the street has put in, a level 16 PET scanner, well then they themselves, this other hospital, in order to compete and to draw in physicians and patients, has to put in a level 16 or whatever, I'm making this up, PET scanner. So that's not really rational. That's expanding capital, that's consuming capital in healthcare just for marketing reasons and not really for health outcome reasons. And that's part of what makes things go so out of control. Instead, if you actually give hospitals and groups and regions an annual budget that here's your capital, here's your operating expenses, and you can't short staff your nursing units in order to fund your new PET scanner, you can start to get regional planning on this. Hospitals and physicians today are spending a lot of time optimizing our payer mixes, looking to see which insurance company is going to pay us more than the other one and trying to get the most of those patients and the least of the underpaid. And that goes away under this. They spend a lot of time shopping between insurance companies, negotiating all of that. Instead, they get a single annual budget, and they learn how to, and they can easily manage within that. So you can accomplish these goals, you can align the interests without having to put in arcane spending caps. Is that what you were asking?
Yes, pretty much so. Just to try to somehow limit that ever-increasing those dollars spent. Then how, of course, the insurance companies aren't going to go for this in the least, so how do you approach getting a strong enough lobby to make this a politically viable solution?
Yeah, I think we've learned a lot about that over the last 6 years. President Obama, when he was in the Illinois Senate, was an advocate for single payer. So and he of course we weren't even at the table under the Baucus discussions. So we're not going to have a president who's more supportive and understanding of what value single payer brings. And yet he didn't come anywhere near getting a single payer program. He didn't even touch it, really. So to me, the lesson from that is that it's not about a top-down decision from the president delivering this to us. It's about discussions like these. It's about discussions like your friends then talking to their friends. It's about building an undeniable grassroots movement so that when we have a critical event, like in civil rights, the Rosa Parks thing that was orchestrated and planned, so that we're ready, we have fertile soil, so that people understand this, they realize it's the right answer, and they help advocate for it. It's going to take all of us doing that, electing more and more sensitive and supportive politicians. It's going to take a broad-ranging movement, but we can. I mean, major social change usually looks impossible 2 years before it happens, and then 2 years later it looks like, well, why didn't we just do that 30 years ago? So I don't know if we're 2 years out or if we're 30 years out, but you know, we can definitely do this.
Yeah. Okay. Thank you.
Anyone else?
Yeah. Could you speak to the public agency that would manage the single payer system and the healthcare budget? Because that's I get a lot of questions about that. How does that stack up as you see it?
Well, I think that's a really important question, because at the end of the day, the governance of a program determines how the incentives are aligned and how the decisions are made. And so improper governance would be a disaster. And under HR 676, there is attention to that, where there's an independent board that has pretty good, diverse representation. So it's got some physicians, it's got healthcare advocates, patients, all the interests you would think should be involved in it. They're all labor. They're all sort of at the table making these overall decisions about the budget, about staffing, and about all of these other things that are so important. The governance of it is very important. They're appointed essentially through the president, and then they're independent, and they're banned from having any conflicts of interest in the process. I think that particular piece, having this independent governing board, is critical to making this happen.
Yeah, I think to get a grassroots groundswell, there needs to be at least a perception of a firewall between the management oversight and the government. Yeah.
Yeah, I agree, especially in states like mine where you can't mention the word government, still leave the room standing.
Thank you for a good presentation. Your slides are nicely done, and I like the way you progress in many of the slides. You progress and fill in the graph as you talk.
I was worried that wouldn't come across on the webinar, so the builds actually worked right. That's great. Well, good. All right, I think that's, I don't know, Ed or Matt, if you have anything else you want to weigh in with, or I guess we're done.
Are we permitted to use your slides?
Actually, I charge $350. Of course, yes. Yes. And I just realized that I built them with the logo for my state. So if you need them changed to a logo for a different state or just a national one, let me know, and I can fairly easily make that adjustment to them.
Okay, thanks.
But yeah, do what you want with them. Have your way with them. I mean, most of these slides are actually Dave and Steffi's slides that I just sort of reformatted and prettied up a little bit. But the content is 95% from them.
Okay.
Is that on the PNHP site?
It should be. It should be up there as one of the slideshows.
Great, thank you.
Okay.
Thank you.
Thank you very much.
All right, thanks. That concludes our webinar. Bye now.
Thank you, Ed.